There's also a primary care, Psychopharm and primary care book. Are you familiar with that one? That's good. There's a new edition out of that. Which one? But there's some good books that are out there. That like one day I travel a lot, so I was on a plane. I could read the whole book on a plane. I mean, it didn't take me that long because they're short. Something. But even if you just I think people in practice. I think people are more fearful about this stuff than they really need to be. The exam is not. It's hard, but it's not that hard. When is he graduating? So you just sent him to college or not? See, now's a great time. You knew you had that window, yeah, where you can do it. I'm glad you're here. It's great. Oh, good. All right, I'm going to remember that.
Okay, guys, I think we're going to get going again in the interest of time and leaving a little bit of time left over for questions. So now we're going to start talking more about treatment approaches in the DBP clinic and also in your clinic. So first-line therapy for ADHD, it's important to emphasize that it's not just medication treatment, it's medication treatment and or behavioral interventions the evidence-based behavioral interventions for children, including parent training and classroom modifications. But very pertinent to our last question, there's no proven benefit for vision therapy, as well as things like interactive metronome training or occupational therapy in the case of ADHD symptoms. So to chew on this question, what class of ADHD medications are considered first line, and what percentage of children with ADHD respond to this class? Absolutely. So the psychostimulants are considered first line, and they are broken into two broad families, the methylphenidate family and the amphetamine family. Important to note that both of these families have FDA approval for over 50 years. So we have really extensive experience with their use, and we can call upon that when answering questions for families. So as far as the methylphenidates go, they are then subdivided into the DL methylphenidate, which include both the right and left-handed isomers, and some of the trade names for the DL methylphenidates are, Ritalin, methylene, Metadate, Concerta, Daytrana, and Quilivant. As far as the D-methylphenidates, that's just the right-handed form of the molecule, trade names Focalin. And so you might wonder, okay, what's the difference between those two isomers? Well, the D isomer is the one that's rapidly taken up into the CNS, and it's the one that has methylphenidate's therapeutic effects, whereas the left-handed form, L-methylphenidate, isn't taken up into the CNS. So when the manufacturers created Focalin, the idea was, well, we'll just give you the part that has the therapeutic effect and not the one that doesn't. So theoretically, there should be fewer side effects, but really in practice, we don't see that, Focalin is side effect free and so much better in terms of side effects than the DL methylphenidate. But it is important for you to, it is nice to understand this though, because the dosing is going to be different for the two different preparations. So for the DL methylphenidates, for the oral preparations, 2 milligrams of those DLs is going to be, that's equivalent to 1 milligram of the D-methylphenidate, the Focalin. So, so 10 milligrams of Ritalin would be equivalent to 5 milligrams of Focalin. Now the Daytrana, the patch, the bioavailability is different, so, kind of the dosing equivalence is different. So for the amphetamines, they are broken into two large groups. So you have the DL amphetamine, so both the right and left-handed form. Generic name of that would be mixed amphetamine salts. And then Adderall is the trade name. And then you have D-amphetamine or dextroamphetamine, just the right-handed form, and that trade name is Dexedrine, as well as Vyvanse. Now the special thing about Vyvanse is that is a lysine, an amino acid hooked to a dextroamphetamine. And so in order for that to become pharmacologically active, the body has to cleave the lysine from the dextroamphetamine. And we think this reaction happens in the red blood cells. And so that limits the abuse potential of Vyvanse. Now, both the right and left-handed form of the amphetamine molecule, both of them do have therapeutic activity. So psychostimulants are considered first-line treatment because they have the largest effect size, which is the amount of change in ADHD symptoms for any ADHD medication class. And they also have the highest percentage of responders of any ADHD medication class. So if you give any kid with garden variety ADHD either a methylphenidate or amphetamine, studies show that you'll get a beneficial response in 70 to 75% of patients. And then if you try a full, if you try a range of stimulants in both the methylphenidate and the amphetamine dextroamphetamine families, you can get a beneficial response in over 90% of patients. So if you do get a beneficial response from the stimulants, you can expect to see a decrease in core ADHD symptoms, so that inattention, hyperactivity, and impulsivity. And then you can also see improvements in some of these related issues like non-compliance, aggression if it's impulsive in nature, like they just kind of reacted, but later on they feel kind of bad about it. This is not kind of the cold, calculated kind of aggression that wouldn't help with that, but it would help if it's impulsive. Also, they can improve, been associated with improvements in social interactions, probably because they're not so hyperactive and impulsive, as well as academic productivity, how much they're getting done, as well as and academic accuracy. So families will sometimes ask, well, how do stimulant medications work? So it's always nice to have that answer at the ready. And in understanding it, it's often helpful to think about, well, what do we think is wrong in the case of ADHD anyway? And so we think that it's because there isn't enough availability of dopamine and norepinephrine in the synaptic space so that the neurons can talk to each other effectively. So there are these things called the dopamine transporter and the norepinephrine transporter, and they're on the presynaptic cell, and what they do is actually that red circle should be moved up a little, so it's that purpley thing on the presynaptic cell, and so they act as sort of vacuum cleaners, and they suck the dopamine and norepinephrine out of the synaptic space. And so the stimulants work by blocking both the dopamine and norepinephrine transporters so that you get more availability of the dopamine and norepinephrine in the synapse so that it will activate the postsynaptic cell, has more time to do that, and the neurons can talk to each other better. So this is my first time, so I hope I'm doing this right with these multiple choice questions. So is one type of stimulant generally more effective than other types? So is it A, amphetamines are generally most effective, B, DL-methylphenidate, C, D-methylphenidate, or D, the efficacy of the different stimulants groups doesn't differ on average? Okay, so you guys all answered in the way that, if we had asked this question like 6 months ago, this would have been like, yes, absolutely, it doesn't differ on average. But there was actually a meta-analysis that was published in the past year in which they found that generally, on average, youth with ADHD treated with amphetamines or methylphenidates do improve, but there seemed to be a marginally larger improvement in clinician ADHD symptom ratings for amphetamines compared to methylphenidates. So this is, again, definitely a new and different finding, and that's why meta-analyses can help us understand things that kind of all the individual studies, it can be hard to appreciate. But we do want to note that this, again, is sort of on average, that most people respond to either one, but amphetamines may have a marginal edge. But we definitely do have a good percentage of patients, 25%, that are preferential responders to one of the groups. So they only respond to methylphenidates or they only respond to amphetamines, but not both of them. So if you have tried one group of the stimulants, you've tried methylphenidates and they don't respond to those, it's absolutely worth your while to try the amphetamines or vice versa. But unfortunately, there's no current way to predict what's going to be the best stimulant for each individual patient. As far as side effects, all the same side effects are possible for methylphenidates and amphetamines, with the more common side effects including things like decreased appetite. That's the most common one that we see, as well as trouble falling asleep, stomach aches, headaches, nervousness, irritability. We can also see social withdrawal or being overly focused. But interestingly, a recent meta-analysis that was the same one published in The Lancet indicated that overall side effects, including things like sleep and emotional side effects, seem to be more prominent with dextroamphetamine amphetamines compared to the methylphenidates. So the conclusion of this article, even though there was this marginally better symptomatic improvement with the amphetamines, is that, this is speaking about the child data, is that for children they would actually have stronger support for the starting with the methylphenidates. But again, I do want to point out with this tolerability finding that, response does vary by individual. Even so, I absolutely do have patients in my practice that seem to tolerate amphetamines better than methylphenidates. This is just kind of when you have a large group of people, kind of where do things seem to tend. So this study by Efren et al. It was published back in 1997. This is kind of illustrating that point. So these are side effect ratings, and the higher ratings indicate more side effects, and the yellow bars are dextroamphetamines, and the blue bars are methylphenidate, and they found that there were more issues with trouble sleeping, with irritability, being prone to crying, anxiety, and sadness or unhappiness with the dextroamphetamines, so higher yellow bars, than with the methylphenidates in the blue bar. Although not necessarily worse than their pre-medication baseline, which was green, with the exception of the trouble sleeping, in which definitely that dextroamphetamine was causing more issues there. So the U.S. guidelines, which were published back in, more the, before 2010, and actually the AAP ones, the most recent ones that we had have been stating that to start with a methylphenidate or an amphetamine or dextroamphetamine first, you could do either one as per your inclination as a doc or a parent. But interestingly, the European guidelines have long said that the consensus is to start with methylphenidates, and I think it is because of this tolerability data. And then the other factor that's important to consider is that do you guys know what the most commonly misused or abused stimulant medication is? It's absolutely Adderall. So I think that probably also plays into the European guidelines recommending to try methylphenidates first. So unfortunately, there isn't any way to predict what the best dose of a psychostimulant is. Actually, Pat Curry did ask me a little bit earlier, are we going to say anything about using genetic testing to predict which psychostimulant is going to be the best. And unfortunately, even though those the people who make the genetic tests are brilliant marketers, in the case of psychostimulants, there really isn't a good evidence base to say, they're not really based upon research studies showing that the genetic variations that they're testing are really meaningful in terms of stimulant response. So if you're trying to pick the best stimulant, you can tell families to save their money. They don't need the genetic testing. Now, there is some data, and similarly with the alpha-2 adrenergic agonists, guanfacine and clonidine, those genetic tests, pharmacogenetic tests, are not evidence-based. In the case of atomoxetine, there is some data that it can be helpful. And then for the other things like the atypical antipsychotics or SSRIs, there may be some utility. But for stimulants, I would say, save your money, and the guidelines, we're publishing a new American Academy of Pediatrics ADHD clinical practice guidelines this year, and it will come right out and say, pharmacogenetic testing isn't recommended at this point in time because of the lack of data. But back for dosing of your psychostimulant. So for stimulant control, response to a given dosage is not related to weight in the same way that for antibiotics, we just take the patient's weight and we plug in, into a formula and get the dose. And more is not always better, although it can be in some cases. So just to illustrate this point, so this is these are some dose response curves from a research study I did, and for each of them we see the level of symptoms, so more symptoms being, worse ADHD, and we see baseline before they started the study, what their response was on placebo, on 18 and 36 and 54 milligrams. So for the top left-hand corner, you can see that this kiddo, placebo, they didn't have any benefit. And 18 milligrams, their symptoms stayed high, no benefit. But then 36 milligrams, they got a nice reduction, and even better at 54 milligrams. In contrast, the kid in the top right-hand corner, they got a benefit from placebo. They got even more from 18, but then 36 and 54 milligrams didn't provide any more symptom reduction than 18 did. The one on the bottom left-hand corner, you saw a nice response at 18, even better at 36, but at 54, they actually got worse. And then the one on the bottom right, you can see that this kid didn't have a beneficial response on any of the doses, 18, 36, or 54, the same level of symptoms compared to baseline. So unfortunately, the dose response is not necessarily linear for our stimulants. So our recommendation is that we want to start low and titrate upward. Now the nice thing is that these stimulant medications start to work the first day that you give them, and the duration of effect is based upon how they've constructed the release mechanism. So you've got short-acting preparations that were constructed to be a 4-hour medication. You've got some long-acting ones like, say, Ritalin LA or Metadate CD or Adderall XR that were constructed to be more like an 8-hour preparation. And then you've got some that were constructed to be more like a 12-hour preparation like Quillavant or Vyvanse, Concerta. They say 12, but practice probably hardly anyone ever gets that much out of it, but anyway, there's a range you can get between 4 and 12 hours. The psychiatry guidelines have recommended that you try each dose for at least 3 days, and then if you're not getting, therapeutic benefit, then you can increase. American Academy of Pediatrics recommends you try each dose for 7 days, and then if you're not getting benefits, then that's a good enough trial. Then you could try a higher dose and see if things go better. So somewhere in there, 3 to 7 days to try each dose, and you want to continue your upper titration either until symptoms remit, the family is feeling like they're getting good therapeutic response, the teachers are reporting the same, or obviously if side effects are problematic, then you're not going to keep going up, or if you reach a max dose, you also are not going to want to keep going ad infinitum. So now what if Luke's parents are concerned that, they're saying like, look, let's pretend he has tics, and they are really concerned about starting stimulant medications. Yep, so there's little evidence that stimulants worsen tics on average in clinical trials. In fact, there are some studies that indicate, that some patients may have improved tic severity compared to placebo. Now the question is, did that kid ever really have tics, or were they just really fidgety and people were interpreting them as tics? But suffice it to say that on average, it doesn't seem like for every single kid that things are worsening, and so it is still recommended to try stimulants first when children have comorbid ADHD and tics. Of course, there are some individuals that do have new onset or worsening of tics with stimulants that you very nicely, document and prove to yourself that every time you take away the stimulant, the tics go away, and then every time you put it back, it comes right back. So that does happen, even though it's not the majority of children. So if the stimulants did show an intolerable worsening of tics, what are your options? Could you A, try atomoxetine monotherapy, B, could you add an alpha agonist to your stimulants, C, would you start an SSRI, or D, A or B? Okay, so yeah, absolutely, A or B, and we're going to talk a little bit about atomoxetine as well as the alpha agonists now. So atomoxetine was approved by the FDA in 2002, so we've got I guess we're 15 years, a little 15 plus, with our experience with it. So it works by blocking the norepinephrine transporter so that there's more norepinephrine availability in the synaptic space. It doesn't have affinity, doesn't block the serotonin or dopamine transporters. Although there is some data suggesting that perhaps in the prefrontal cortex that the norepinephrine transporter may do the work of the dopamine transporter, that there aren't so many dopamine transporters available in the prefrontal cortex. So maybe in the prefrontal cortex, atomoxetine may give you a little bump in your dopamine, but certainly it's been documented that atomoxetine doesn't increase dopamine levels in the striatum. And since tics have been linked to having excess dopamine in the striatum, this is why mechanistically there isn't a reason why atomoxetine would worsen tics. And also in research studies, it hasn't been shown to worsen tics. That doesn't mean, of course, that families, because of, kind of things happening coincidentally, might not be, some rarely will be convinced that it might worsen, but again, scientifically, we don't think so. So as far as atomoxetine response rate, so the reason why it is not first line is that it is lower than the stimulants. So somewhere around 35 to 50% seem to get a beneficial response. There's also a smaller effect size, so a smaller amount of change in ADHD symptoms for atomoxetine compared to the stimulants. As far as the side effects, so stomach upset, nausea, and vomiting. So the stomach thing is one that we hear about more commonly if we're going to hear about anything. And this can be minimized by administering the atomoxetine after the kid gets some good food in them. Diminished appetite can also be seen, although that is generally less than what we see with the stimulants. Something that families will talk about sometimes is they seem sleepy, they seem more fatigued with atomoxetine, in which case we would move it from morning administration to nighttime administration. And then rarely we will see irritability or mood swings. And when we see this, it's usually pretty marked. And so we do want to tell people that this might be the case and that we want to have them call us right away if they see this off the hook irritability. And pertinent to that, there is a black box warning on the atomoxetine for suicide risk, and this is because in controlled trials, suicidal ideation was 0.4% for atomoxetine versus 0% for placebo, and there was one suicide attempt out of over 1,300 patients who were in the research studies, although there were no completed suicides. And it's thought that the kids who are at risk for suicidal ideation with atomoxetine are the ones that get that super irritable off the hook. So you want to tell families, look, watch for this and call us right away and we're going to stop it if we're seeing that. Adverse effects on the liver with atomoxetine are also possible but rare, so it's not recommended that we check liver enzymes routinely, but if a kid has underlying liver condition or if they're on a bunch of other meds that can affect the liver, we do want to be really careful. And psychosis and mania can be seen with atomoxetine, although they're very rare. So as far as getting started, we start with a lower weight-based starting dose. So it's generally around 0.5 milligrams per kilogram per day. And we usually do that for somewhere 4 to 7 days. And then we increase to a weight-based target, which is usually around 1 to 1.4 milligrams per kilogram per day. Once daily dosing can be used, although some studies have found that efficacy and side effects may be improved if you give BID dosing in the early morning and early evening. Now, unfortunately, though, insurance companies are often not going to let us have the BID dosing, so even if these research studies are indicating some better effects, it's often not an option to us anyway. So although effects with atomoxetine can be seen as early as 1 to 2 weeks, maximal effects may not be seen for 4 to 6 weeks. So you really have to be at the full therapeutic dose, so not that low starting dose, but your kind of target dose for a month to determine whether or not this atomoxetine is beneficial. So it does require a lot of patience on the part of the family. So they have to be aware of that from the get-go. As far as the alpha-2 adrenergic agonists, so the generic names are guanfacine and clonidine, and for guanfacine, the trade names are 10X, which is the short-acting form, and Intuniv, which is the long-acting form. For clonidine, the trade name for short-acting is Catapress, and for long-acting is Capve. And these are newer, so less than 10 years since the Intuniv and Capve have been FDA approved and had the indication of ADHD. So guanfacine and clonidine work by stimulating the pre and post alpha-2 adrenergic receptors, which controls the norepinephrine release and firing rate. So they do not have dopamine effects, so they also would not be expected to exacerbate tics, and in fact they are used as a treatment for tics. Guanfacine selectively binds to the alpha-2A adrenergic receptors, whereas clonidine binds to alpha-2A, B, and C. And so that is a reason why I use that kind of fact to help myself understand that side effects do seem to be more so with clonidine compared to guanfacine. So clonidine and guanfacine can decrease hyperactive symptoms. The clinical consensus is that the effects on attention are not as robust as with the stimulants. The response rate is also more on the order of what we see with atomoxetine, more around 50%, and the effect size change in ADHD symptoms is less than what we see with the stimulants. Although, as I indicated, a nice benefit for them is that they can be used to treat tics. So in general, again, the side effects less for guanfacine than clonidine. The most common side effect that we'll hear from our families is sedation or somnolence, but if you start on a low dose and you warn families that's going to happen and you say, hey, if it's not the most terrible thing, if you ride it out for 3 days, for a week, that'll often get better. Other side effects that we can see are dizziness, irritability. Usually makes them calmer, but again, with anything, you can go the wrong way and get more irritable. Headache, abdominal pain or constipation can be seen, and rarely hallucinations or mania can be seen. So like stimulants, you want to start at a low dose and titrate upward. Like atomoxetine, max treatment effects may not be seen until 1 month at the full dose. So again, they've got to be really patient in trying the alpha-2 adrenergic agonist. You need to warn them so that they don't, after a week on it, if they're not seeing much, they don't, kind of dump it. As far as the cardiovascular effects, so these medications, guanfacine and clonidine, were originally developed as blood pressure lowering medications. So they can cause hypotension, less so for guanfacine than clonidine, and it's usually not so much in the doses that we give for ADHD, but you should be aware that this, again, is usually not huge at our doses, but we need to monitor the blood pressure. We need to warn the families that overdose can be fatal. I remember about 10 years ago, there was a famous case in Massachusetts where a kid was given so much, I think it was clonidine, that he actually died from cardiovascular failure. So you want to have it in a place where kids or pets cannot get a hold of it. And also, families need to be warned that they can't just stop it cold turkey if they're on something above the starting dose. Rather, it should be weaned down, and that's because if it is holding down the blood pressure a little bit and you stop it cold turkey from a more moderate or higher dose, then you can get rebound hypertension where the blood pressure really shoots up. Another along the lines of hypotension as a cardiovascular side effect, sometimes the blood the heart rate can become a little bit slower too. So now Luke's parents, they want to know if stimulants and atomoxetine typically have cardiovascular effects, since we've talked about the cardiovascular effects for the alpha-2 adrenergic agonists. So you reply that mild increases in heart rate, so on the order of less than 10 beats per minute, and mild increases in systolic and diastolic blood pressure on the order of less than 5 millimeters of mercury have been observed with some ADHD medications. Is this true for amphetamine, dextroamphetamines, A, B, methylphenidates, C, atomoxetine, or D, all of the above? Okay, so you guys are good. I got to hand it to you. So it is all of the above. And, sometimes families think, oh, I'm worried about cardiovascular things with stimulants, so let's do a non-stimulant. But atomoxetine can also cause some of these parameters to increase, as well as the adrenergic agonist can cause them to decrease. So you have to think about heart things with all of the FDA-approved ADHD medications. So prior to starting any of these stimulants, atomoxetine or the adrenergic agonists, the guidelines do recommend screening patients for a personal history of cardiac symptoms. So do they have congenital heart issues? Do they have syncope with exercise? Do they have hypertension? Do they have unexplained shortness of breath? Things like that. And you also need to ask about family history of cardiac risk factors for sudden death, things like sudden death with exercise, sudden death or cardiac death or a myocardial infarction at less than 40 years old, or arrhythmias or channelopathies, things like Wolff-Parkinson-White, long QT syndrome, or Brugada's. And then if they have any of these risk factors, either personal or the family history, then you want to get an EKG and possibly get a cardiac evaluation to make sure that we're safe in terms of our cardiac things. So now, what about sleep? What if Luke's baseline difficulties falling asleep worsen with stimulant treatment? What options do you have? And I do want to point out, though, that it's not the case that every single kid who tries stimulants is going to worsen with sleep. And in fact, we published a paper last year in which we found that the kids who had moderate to severe sleep difficulties at baseline before even starting stimulants, that they didn't worsen in their sleep problems on methylphenidate. And in fact, some of them got better, where it was more the kids who didn't have any baseline sleep difficulties that were more at risk for sleep problems with methylphenidate. But anyway, let's say that his baseline difficulties do worsen with the stimulants. So your options could be continuing stimulants, but adding a melatonin at bedtime. It's a hormone produced by the brain that sets the sleep-wake cycle. And I think this was talked about in the session in the morning. You could also continue the stimulants, but add some clonidine at bedtime to help with sleep initiation. Or you can switch from stimulants to atomoxetine, but warning the family that, we're switching to atomoxetine, but we may not get our therapeutic benefits for a month, so we're going to need to continue the stimulants for a month until that atomoxetine hopefully will kick in. So what if you determine that Luke has comorbid ADHD and oppositional defiant disorder? You tell his parents that medications that have been shown to improve ADHD and oppositional behaviors include A, stimulant medications, B, alpha-adrenergic agonists, C, atomoxetine, or D, all of the above. Oh, get on a timer. Okay, yes, it is all of the above, although the effects of atomoxetine don't seem to be as robust as the stimulants, for instance, for oppositional defiant symptoms. So what if Luke requests that his stimulant medications be changed from a long-acting to a short-acting formulation? So what is most concerning about this request? Is it A, the likelihood of non-adherence to his medications is higher with the short-acting formulations? B, short-acting formulations have higher potential for abuse than long-acting? C, there is a cost difference for short versus long-acting? Or D, his ADHD symptoms will be less controlled, well-controlled with the short-acting? So the answer is B, the short-acting formulations have higher potential for abuse, although a number of these things can be true, although I would not consider them to be the absolute most concerning thing. So it is true that the long-acting formulations have better adherence than the short-acting formulations, and it is also true that because you're getting better symptom control throughout the day, and don't have as much of that down, and we haven't given our other dose of short-acting yet, that oftentimes the control of symptoms can be better with the long-acting. So parents are often super concerned that giving their kids stimulants is like giving them crack cocaine. And so to address this, there was some really great study done by Nora Volkow. She is the head of the NIDA, so National Institute of Drug Abuse. And so she did this study in which she gave patients IV methylphenidate, and then she gave them the same dose of short-acting oral methylphenidate. And what she found is that for the IV administration, the peak levels in the striatum of the brain, so that's the part of the brain that's involved in drug liking and euphoria, drug abuse, the peak striatal levels for IV were hit after 8 to 10 minutes. So that's that green line that goes like straight up. And that rapid rise in the methylphenidate levels was associated with a feeling of high and drug liking. Whereas the short-acting oral methylphenidate, the purple line, the peak striatal levels weren't hit until after 60 minutes. And so this slow rate of rise was not associated with feeling high or drug liking. And in fact, for the for many of the sustained release forms, there's an even longer delay in reaching peak brain levels, and so that's why it's thought that there's even less abuse potential with the long-acting than with the short-acting. Now, non-stimulants do not have abuse potential as they do not increase striatal dopamine levels, as we've been discussing for the atomoxetine, as well as the alpha-2 adrenergic agonists. For the sustained release stimulants, extracting the medication to achieve a high quickly, which can be done with the short-acting preparations if they're snorted or injected IV, it's more difficult for some of the sustained release forms. And so they are they're harder to abuse. And so that would include the lisdexamfetamine Vyvanse, because it's hooked to the lysine and the body needs to have this enzymatic reaction to cleave the lysine from the dextroamphetamine. Also the dermal methylphenidate, the Trona patch, and the Oros methylphenidate osmotic pump release system in Concerta that just really, they're constructed in a way that's really hard to extract the methylphenidate from it and then snort it or IV inject it. In addition, it's important to let families know that many, many studies, including a number of meta-analyses, have looked at whether or not there's an association between stimulant medication treatment during childhood and later substance abuse risk. And they either found no effect, so getting treated with stimulants for ADHD in childhood did not increase your risk of substance abuse later, or they found a beneficial effect that being treated as a child with stimulants for ADHD led to a reduction in later substance abuse. And so I think this is really good data to reassure families that, we're not, there's no evidence that we're kind of putting them on the path to drug abuse if they're using their stimulants appropriately and taking them orally and as directed. So as far as treating comorbid ADHD and anxiety or depression, it's really important to emphasize behavioral interventions and counseling and some of the things that Casey talked about with us today, the cognitive behavioral therapy to help with anxiety and depression. As far as if you're thinking of medication treatment, you want to figure out which disorder seems to be driving the bus and causing the most impairment. Is it the ADHD or is it the anxiety or depression? Figure out which one of those is most severe and begin treatment for that disorder. Don't begin treatment with medications for both at one time, because then it's really hard to determine which one is really helping, and treatment for one may improve symptoms of the other condition. And again, you don't want to go there with polypharmacy if you don't have to, including due to the risk of drug interactions. Important thing, people often worry, oh my gosh, stimulants, they're going to worsen anxiety and mood, and this is not necessarily the case. In fact, for anxiety and sadness or unhappiness, there was significant improvement with methylphenidate in these two compared to pre-medication baseline. And this was corroborated by recent meta-analysis by Pazzi et al., which found that on average, compared to the child's pre-medication baseline, methylphenidate reduced both irritability and anxiety. Amphetamines, though, did seem to have a risk of worsened emotional ability compared to pre-medication baseline. But again, I want to emphasize that these are things, kind of on average, what you're seeing in groups of people, and response does vary by individual. As far as treating ADHD and anxiety or depression, if the clinical situation suggests treatment for ADHD first, as mentioned, you can initiate stimulant therapy. If the ADHD symptoms improve but anxiety or depression doesn't, you could consider adding a selective serotonin reuptake inhibitor. You can also consider atomoxetine because in some studies it's been shown to have mild beneficial effects on generalized anxiety, separation anxiety, and social phobia. In the case of ADHD plus depression, bupropion, the trade name of that is Wellbutrin, may also be an option. It's an atypical antidepressant. It does have weak affinity for the dopamine, norepinephrine, and serotonin transporters, leading to increase of all three of these neurotransmitters in the synapse. Since it has weak dopamine effects, it can have weak beneficial effects on ADHD symptoms. Be aware, though, I was going to tell you that you can consider combining it with stimulants, since it's usually not going to be, pow-wow super effective for your ADHD symptoms. With psychiatrists at Cincinnati Children's will often talk about it's those kids that seem to have the more angry depression that they feel like Wellbutrin can be, or bupropion can be particularly helpful. But it is contraindicated if a kid has seizure disorder. Now, we did want, Susan prepared these fantastic slides about SSRI treatment, and so I think we're doing so well with time that we want you guys to be able to have her go over those as well. Now, wait a second. I'm not sure, because I can see her slides on my screen, but maybe I have to start slideshow.
Can you help us?
Yeah.
And these are supplemental slides in your handout.
There.
Yeah.
Oh, they're in the extra supplemental section.
It's a separate handout.
Oh, you want to put that there?
Yeah, so. Okay, there we go.
Thank you. Okay, is everybody still awake? Okay. How many of you prescribe SSRIs? Oh, good, everybody does. So then this is just a review for you. I just wanted to go over medication for depression and anxiety in children and adolescents. And, oh, that's interesting. So it doesn't go forward on the screen, but it is there. Okay, that's all right. I could deal with that. So in terms of anxiety disorder, no medications have been approved for anxiety disorder by the FDA except for OCD. And this is all due to the challenge of doing studies because there's so many definitions of anxiety. So really there haven't been good studies done in terms of the use of SSRIs in children and adolescents. And so the use of medication to treat anxiety with SSRIs is considered off-label. So you need to know that because you probably need to talk to parents about that. You need to talk to kids about that. Probably need to document it in their chart just to keep yourself safe on the safe side because these are being used off-label. However, there are medications that have been approved for OCD and depression. So this chart, I think, is pretty helpful. And if you're going to be prescribing SSRIs, it might be something that you want to use as a guide. And I'll just go through the drugs real quickly. So fluoxetine, which is Prozac, probably there's the best evidence about the use of that for anxiety and depression in children. People use that pretty often. Do you guys do that? Use Prozac, fluoxetine? And so for major depressive disorder, it's approved from 8 to 17 years. For OCD, 7 to 17 years. And the initial dose is 10 to 20 milligrams, and the maximum dose is 60 milligrams. I'll just talk about these individually. I think it'd be easier to do that. I think that Prozac works really well for anxiety and depression. It's really a great drug for younger children. And one of the things that I think you probably see a lot is your school-age kids who have anxiety that's so great that they can't function, either separation anxiety or social anxiety or just generalized anxiety disorder where they can't sleep. The thing that I think is very helpful to do is to use the oral preparation of the fluoxetine and dose at a very low. You can dose it very low. So you can start at 4 milligrams, go up to 8 milligrams. And I have a lot of kids that are on that, and it seems to work very well. Parents really appreciate the low dose, and it is amazing to me how in those low doses you can really change kids' lives. So consider using the liquid preparations, particularly for all these medications, because in the liquid preparations you can keep your doses really low. You agree with that? Okay, good. They do come in capsules. And then weekly capsules I've never used, and then oral solution is the 20 milligrams per 5 cc's. You do have to be really careful, though, because this is such a small dose. You know, it's like 1.25 milligram cc's or 2.5 cc's. So I'll usually write on the prescription that please administer to the pharmacist, please administer a syringe when you're giving this medication. Escitalopram is Lexapro. That's the only FDA approval is for 12 to 17-year-olds. The initial dose that's published is 10 milligrams, but I start at 5 milligrams with most patients, most kids, even teenagers, and unless they're really huge. And then the maximum dose is 20. It comes in tablets, and then there's also an oral solution, but that's 1 milligram per 1 milliliter, so you have to really consider that dosing again, be real careful about that. Sertraline is great, that's Zoloft. That's only indicated for OCD in 6 to 17-year-olds, and the dose is around 25 milligrams for 6 to 12-year-olds and 13 to 17-year-olds, 50 milligrams. Maximum dose is 200. And this comes in tablets and oral solution. And with sertraline, again, I use this in younger kids, and it can be very effective, and you can start at 12.5 milligrams, again, that very nice low dose. Citalopram, it's not part of the FDA approval, but it is recommended if you look at the GLAD-PC guidelines, they do include that as one of the medications. There are a fair amount of side effects with citalopram, but if you have, the other thing I want to mention is that one of the key questions when you're prescribing SSRIs is to ask the parents what they take or what their father or the grandmother takes or something, and then go with that. And that, I have tons of questions from parents around the genetic testing. And there are some, I'm sort of on the fence with that. I did that for a while in our practice. It wasn't very effective, and you always worry about cost. A lot of the psychiatric practices are using the genetic testing now to help guide their practice, particularly with SSRIs and with other drugs for depression and anxiety. So, but I would ask the family members what they take or what someone in the family takes. And then generally you hope that there's that sort of pharmacogenetic effect that works for the kids. Fluvoxamine is really not used in the United States, although in all the publications you see that discussed, and it's been approved through the FDA. I'm going to keep going. So here's just a summary of what we just said. So we know that no SSRIs FDA approved for anxiety, but many studies have demonstrated the effectiveness of fluoxetine, sertraline, and the fluvoxamine for the generalized anxiety disorder. And again, consider the use of the drug that's worked well for a parent or a sibling. So this is just a list of, for depression, fluoxetine and escitalopram have been approved, so you probably want to use those first. For anxiety, the fluoxetine and sertraline. Keep in mind that fluoxetine has a very long half-life, and so that's good for kids who skip their doses. And it's something that in terms of tapering, you want to keep that in mind when you're tapering kids off. The effective onset is 3 to 4 weeks. And here are some of the side effects: abdominal pain, discomfort, and you may see improvements with sleep. I generally prescribe these medications at night, just because it does help sometimes with sleep, particularly for your anxious sort of child, and that it may mitigate some of the side effects as well. So we know about black box warning, that all these medications have a black box warning. And I think we do need to talk about that. I'm going to go over some of the evidence that really is no evidence that this causes suicide. But you do need to mention that if the child's mood worsens, if they become more emotional, that they need to contact you. It is recommended to follow these kids pretty closely to monitor for worsening or emergence of suicidal thoughts and behaviors. Do talk about serotonin syndrome. That is a real serious problem. Describe that to families. We want to make sure they know that if kids have a sudden onset of fever and they're out of it, that they should be seen right away. Certainly, if mania occurs or hypomania, seizures, all these other things, that we need to have kids seen right away. One thing to keep in mind is that generally the side effects are transient, and so you should warn parents about that, and that's usually over the first couple of weeks, and that can improve in time. So sometimes kids just need to hang in there, but if they're more serious, they need to contact you. And when they are discontinuing treatment, we need to really emphasize that there is a possibility of discontinuation syndrome, which is really not a good thing. And so we want to tell parents that we have to taper them on and taper them off. I've had a lot of questions from people about when you're tapering down and you're starting another SSRI, how do you do that? And so essentially you taper down on the first one and you taper up on the second one, and you can do that simultaneously. You're always monitoring your height, weight, blood pressure, pulse. Don't forget that your first line of treatment is psychosocial treatments, and I would not jump to SSRIs right away. I think that it's important for us to consider that as an adjunct to our therapy, and in some kids it's really going to be a game changer, but that really just do not prescribe these by themselves, that they need to be done as an adjunctive therapy with psychotherapeutic interventions. CBT works very well for both depression and anxiety, and so you should recommend therapists who are trained in that to do that with the children and the teenagers. Also, interpersonal psychotherapy has been found effective for depression. And the kids who do the best, and this is what I always say to parents, kids who do the best get the therapy along with the medication, but that's really important, that they just can't do the medication alone. You can monitor these kids with using these different tools we talked about today, the SCARE, the PHQ-9, to see that their symptoms decrease over time, sort of the same way that you're checking symptoms with the Vanderbilts. Follow-up visits need to be pretty regularly. We're always worried about suicide, so you need to ask those questions, particularly if kids are really depressed, and you're looking at the different symptoms. You want to check for adverse effects from treatment, and then any kind of new stressors. What's really important, though, is that you're going to be treating these kids for up to a year, 9 months to a year. And then the other piece that's really important is that when you discontinue treatment, that's when kids are at a high risk for the first 8 to 12 weeks after discontinuing medication, they're at risk for relapse. And so you need to talk to parents about that, because when they get off the medication, they could relapse and become depressed again. So you want to monitor them during that period. I just want to mention quickly about these FDA black box warnings. So this was done in 2004, and there's a whole history around it. I won't spend a lot of time. But there was a meta-analysis of about 100,000 participants, and there was some suicidal thinking with 4% of those on SSRIs, 2% on placebo, but there were no completed suicides. And that's really important, because parents need to hear that. They worry a lot about taking these drugs, but what caused the black box warnings was all this research that was done. And so it led to the black box warning, but in fact there were no completed suicides during that time. So we know that what happened after the black box warnings came around, people stopped prescribing SSRIs, rates of suicide went up, and so we don't want that to happen. Here's the black box warning that you can talk about. And so there was a reduction in antidepressant use 2 years after the warning. There was a decrease in use. But there was no, so we need to prescribe this medication. There's a risk versus benefit. I want to talk about benzodiazepines quickly. The problem with the benzodiazepines is that a lot of the mothers or fathers take the benzos, and they'll give them to their kids when they're having a panic attack, and it works great. That's wonderful. But how many of you have seen a teenager addicted to benzodiazepines? It's horrible. It's a horrible addiction. And so I know in our practice we have agreed that we will not prescribe benzodiazepines at all to any children or child or adolescent. If you do, it could be maybe for a plane ride or something like that, but really limit the number that you give, maybe 3 or 2 pills. So you will be asked that question, though, by parents, because they'll say, it works great for me. You'll say, what do you take for your anxiety? And they'll say, oh, I take Ativan. And you're like, oh, great. So, but we really, I mean, if I had my say, I would never recommend that any of you prescribe benzodiazepines to kids or even to teenagers. And I do a lot of teaching with these teens and say, we want to prevent you taking SSRIs, we're preventing you from needing these other medications, the benzodiazepines. There's this thing called Xanny bars. You're familiar with that. It's a very popular drug of abuse. They put a bunch of them together. So we really don't want to use them. Now, hydroxyzine has come out. I haven't seen much literature on this, but it's Vistarel, and it's used pretty effectively for kids that have panic attacks. And so it also helps with sleep, and you can do 10 milligrams for younger kids, 25 milligrams for older kids. I've seen it be somewhat effective. It doesn't have all the somnolent properties that the other antihistamines have. So it's an option for panic disorders. It's something that you can give instead of a benzodiazepine. And that's all I have on that. And now we're going to go back to the end of our presentation.
If we can get ourselves back there.
If we can get ourselves back there, I'm going to
We might need some help with that. Why is the touchpad not?
Okay, this is
Oh, yeah. Okay, so do you guys want to quickly review with some of the educational treatment approaches could be? I think we alluded to some of the ones that Luke had when he was a younger kid. Preferential seating, even as a middle schooler, can still be helpful so that there aren't so many distractions intervening between him and what's being taught. Having a test-taking area that's free from distractions that can certainly help him. He can use timers so that he knows how much time is elapsing, when he's doing his classwork or is doing his homework. Visual aids, color coding folders can be helpful for him. Breaking down instructions into fewer, more concise commands that can be helpful, but usually middle school teachers are not going to, do that for the kids, so that's more of a younger kid thing. Helping kids to learn how to break tasks down into smaller, more manageable chunks. This is definitely something that can be helpful, and often in middle school or high school, you can have written into a 504 plan or an IEP that, one period, sometimes they say one period a week, or sometimes it's just a short amount of time each day when they'll meet with intervention specialists who will help them with kind of breaking things down and with organizing what they need to do. And then teaching kids how to use checklists for assignments with due dates that's really key. So, of course, executive functioning approaches this can be something that parents can work with kids, not just teachers. So kind of, okay, what's your long-term goal? What are all the steps you need to complete? Let's identify them. Let's consider how much time it'll take to complete each of them, and let's plan when we would have to have each of these done in order to get our task complete when we need it to be. And so, again, not just for book reports and longer-term school projects, but this could be for if they're going to make a recipe, if they're going to do laundry, they're going to plan their wardrobe, or if they're going to plan a whole trip. So back to Luke. So he did receive cognitive behavioral therapy to address his anxiety. He got counseling on sleep hygiene and limiting his screen time, and that did help to improve his sleep. He got reading LD and executive functioning related interventions at school, and he got private evidence-based reading tutoring. He got Norton Gillingham tutoring. And we also thought about his medications. So although we know that it's not a strict weight-based thing, we know that he's 40 kilos and he's 12 years old. He's only tried 36 milligrams, so it's absolutely would be recommended if he's not getting as much benefit on 36 as we would like, even though he's tolerating it well, that we should try the next dose up 54 or even 72 before we necessarily dump this medication, which has been effective for him in the past. So if it turns out that neither 54 or 72 milligrams of Concerta are effective, your options could be trying D-methylphenidate Focalin, because some kids may respond differently to D-methylphenidate compared to DL-methylphenidate. You could also try, as we mentioned, the amphetamine dextroamphetamine family, since 25% of kids may be preferential responders to just this one med group, although we talked about how emotional side effects do seem to be more prominent on average, a little bit with the amphetamine dextroamphetamines than methylphenidates. And we could also try atomoxetine, although we mentioned that percentage of responders and amount of change in ADHD symptoms is generally less than what we see with the stimulants. So as it turns out, for Luke, his ADHD symptoms did improve on Concerta 72, as well as we gave him 15 milligrams of short-acting methylphenidate in the afternoon to help with his homework. When we added the reading LD-related interventions and CBT for anxiety, we also saw improvements, interestingly, in his ADHD symptoms. And that's because of many times what we think are inattention ADHD-related symptoms are really due to the kids being checked out at school because they're so overwhelmed, because their LD isn't being addressed, because their anxiety isn't being addressed. So once Luke was keeping up better with his academic work, once his anxiety was in better control, he could really focus more on his schoolwork, and he felt more motivated to do it as well because he felt more effective. So that is the end of our case. So we can now take questions from you guys. All right, I'm going to sit down because we'll kind of share, give you guys a microphone and then we'll share one up here.
Yeah.
A comment about using SSRIs. You've got to make sure you take a family history to make sure you're not dealing with bipolar disease, and be very wary about treating a child with a strong family history for bipolar disease with an SSRI, because even if you stop it, the effects of being treated with an SSRI may not immediately go away. And the second point is the book Smart But Scattered. There are two different versions, a children's version for 4 to 13 and a teen version are wonderful books. And chapter 4 in the teen version and chapter 5 of the younger child version gives you the 10 principles of executive function. Very helpful to parents, very helpful to teachers.
Thank you.
Smart But Scattered.
Smart but scattered.
And the first author is, I think, is Dawson on the younger child, and Guarte is the first author. It is Guarte and Dawson versus Dawson and Guarte for the two books. $14 from Amazon because somebody walked off with my copy of it. I had to reorder it.
Thank you for mentioning the bipolar disorder. I think that's really important. I should have mentioned that in our discussion. You have to be very careful about that. Thank you.
I had two questions, and one relates to developmental assessment, but I see there's other people here with the same background as I was working with children in out-of-home placement. What developmental assessment tool would you recommend? And then I wonder if you could comment on the newer methylphenidate Adderall products out now, the chewables, and you mentioned Quilivant. Yes, and so why did that go away? I didn't understand that.
Yeah, and I'm not sure why Quilivant. Oh, go ahead.
I know why it went away.
Yeah, that's what I thought.
It went away because of Puerto Rico, because of the hurricane in Puerto Rico, and it was produced in Puerto Rico. And we've been waiting for it and waiting for it. It came back for a little bit, now we can't find it again. So it apparently, Puerto Rico doesn't have electricity still. And so that really affected not only the Quilivant, but also some other, medical supplies, I think IV bags and things like that. I don't think is this working? Do you want to talk about, what was the other part of her question?
So you're asking about specific developmental tools for children in out-of-home placements? Yeah, we have a whole foster care clinic. We see all children in foster care in a certain county near us. We give the same developmental assessment tools that we would give to other children. We use the Bailey for young kids. We use the Weschler tools and other instruments for older kids. They are complex cases. We're just more careful in our diagnostic conclusions, given everything that these children have gone through. We tend to try to follow them more over time because they're at such risk for behavioral and developmental difficulties.
Don't worry, I'll get to everyone because we have a lot of time for questions.
So I can just talk quickly about the different preparations that are out there. I mean, I have a list of them. There are so many. And if one of the things we didn't include is there's a medication management guide that's available. If you just type in, ADHD medication chart.
On the handout.
Oh, it's on the handout. It is awesome. So it's a big picture of all the preparations that are available for the amphetamines and the. Yeah, and it was just updated.
It's the top, like in the second section, it's the top.
It is wonderful, and it's a picture, and you can actually show it to families. I mean, I have it laminated, and yeah, so, but make sure you have the most recent edition. I think it was March of 2018. No, there's one from March 2018, and it is wonderful. And so that has all these new ones like Adensis, Avicchio, and so the only thing that I would say is that you have to think about are you prescribing methylphenidate, are you prescribing the dextroamphetamine? And these preparations that are all these brand names are not going to be covered by formularies, your insurance formularies. And so I think you're okay prescribing methylphenidate ER, which is what you have to do, because that is the only thing that's going to be paid for. They cost $300 to $400 for these different preparations. And some of them are chewable, some of them are liquid, which is great. There's a new one called My Day Is. Have you heard of that? That's for 16 hours. And so, I have not used that. I don't know if people have. That's through Shire, I think. It's the people who do Vyvanse. So there are different preparations out there. I think that, use the chart, use your information. You have to do a prior authorization to get probably any of these other ones covered. So that was what I would say about that. Do you have anything else, Tanya?
Yeah, I was going to say the same, that the cost is often so limiting. And when I have tried them, I haven't gotten different effects than, the more tried and true ones that have been available more and are covered and cheaper.
Okay. Other questions?
I was just going to say, My Day Is really simple to prescribe because with the coupon, you don't have to go through the prior
Okay. So she said, if you can use the coupon for My Day Is, and I know the same is for Vyvanse, you can use there are coupons available through the drug reps. Some of the facilities don't let drug reps come into your facilities, in which case then you can't really use the coupon codes. But parents can even go online to get the coupons for some of these medications, so it's probably worth trying if you really need to do that. Any other questions?
I was wondering if you could speak a little bit about medication management in preschoolers with ADHD.
So the American Academy of Pediatrics recommends that you start with a methylphenidate. So even though dextroamphetamine has FDA approval for the preschool age group, it received this approval at a time when it wasn't very stringent to get the FDA approval. So there's really a lack of research study that approval is based upon. We really have many more studies, including this very large landmark trial called the PAT study of methylphenidate use in preschoolers, and it seems to be effective and safe, although the side effects seem, especially the emotional ones, seem to be more prominent than what you see in school agers. But yes, start with a low dose of methylphenidate first, and that would be preferred compared to a dextroamphetamine or compared to an alpha-2 adrenergic agonist, which a lot of people do, but again, there's a lack of research kind of study to base that practice upon.
What are your thoughts on giving medications daily versus taking breaks for weekends and school holidays, stimulants specifically?
So this is what I say to parents, is that if the child functions, it's all about function. If the child functions better on the medication, feels better, their self-esteem is better, they're not being yelled at all the time, then you might want to consider, and they don't have side effects such as sleep problems, appetite suppression, growth problems, then keep them on it all the time. If they really only need it for academics and they do fine on the weekends and they're not getting yelled at and they feel their self-esteem is intact, then you can take them off during the weekends. But I think it's really an individual, it needs to be done individually, and you really are thinking about that child's self-esteem and self-worth, because as you know, kids with ADHD who get yelled at all the time feel terrible about themselves. And so I think that's really important. I think there's been like one study that shows that sometimes when the kids are off on the weekends and they have to start it on Mondays, that sometimes they have a harder time adjusting to the medication. So that would be another reason why you would probably do it 7 days a week. Okay.
Yeah, I'm basically looking at the same thing. What's the functioning like without it? What are the side effects like? And sort of what's the balance of the benefits versus, the side effects? I don't think that there is one, everybody must take it every single day or everybody must take a break on the weekends. It does seem like, there is some data to suggest that perhaps some of the growth effects may be, if kids don't take it when they're off from school, that there may be less in terms of growth effects. So that is, something to consider, but again, function is so important.
I just wanted to add as far as citalopram, the FDA had some concerns about dosing. They said that there could be issues with prolonged QT on doses over 40 milligrams, and max dose on that is 60, but I would be cautious.
Yeah. I think that's why I was surprised to see it in the GLAD PC guidelines that it was there, but I think that's a really good point, that that's a pretty serious side effect, and we have to be careful of that.
Someone on this side?
I have a very oddly specific question, but I was having a discussion with somebody that worked in the school system, and I said that I oversaw their IEP because I'm their primary care provider, and they said, not to be disrespectful, but you don't oversee their IEP. And so I'm just curious, how do I refer to my role with regards to that when I'm having these conversations with people who work in the schools?
Yeah, I think the schools often feel that we're, telling them what to do or saying that they're not doing things right, and there can be some animosity. So we really want to try to avoid that and try to collaborate as much as possible. I found that getting consent and contacting the school directly is very helpful, rather than just sending our report with all of these recommendations and things that we want the school to do. Technically, legally, it's up to the school to do their own evaluation and to determine what the child is eligible for and what services they're going to provide. If the family is not happy with that, they can, seek some other legal ramifications and advocate. So I think our role really is to help the family understand what services they have, what's benefiting the child, what they need, what they can ask for, but it's really to collaborate with the school. And I found it's best to do that by picking up the phone and calling them directly after you get signed consent to do so.
I would be wary, though, in just bypassing the parents. I think the parents have to be in that loop. So what I do with the parents is, if they want me to talk to the school, I'm happy to have the school contact me, but it's through them. And so when I get rating scales back from the school, it's through the parents, not directly to me.
Mm-hmm.
And the other part of this is, when I send recommendations to the school, I tell the parents to get the full recommendation to school and then ask to meet and just talk about one topic at a time. What am I going to, here are some of the things we're doing at home to work on as an organization. What else from this list do you want us to work on? Can we meet next week and talk about graphic motor skills? Can we meet the following week and talk about some of the reading strategies we're using at home? What else do you want us to do so the parents understand it's a collaborative effort?
Mm-hmm.
But make sure they give the whole report to the school.
Mm-hmm. Yes, good tips. The more communication, the better.
Other questions? Oh, one more.
I was just curious on your opinion on antipsychotics in kids. A lot of times we're seeing, where I work in Lima, we're seeing kids who are on ADHD medications. Schools are going to kick them out if something doesn't improve. We talk until we're blue in the face with parents about expectations and guidelines and, rewards for good behaviors and negative consequences for bad behavior, counseling and those kinds of things. But we need, teachers and parents are saying we need something right now, or, they're going to end up in jail. They're going to get kicked out of school. They're running out of the front door in the classroom. And there's a 6-month wait to get them to psychiatry or developmental peds.
I'm going to comment on that because I do not prescribe atypical antipsychotics. When I worked in the developmental peds clinic, I did. And, it was we were very careful, but there were a lot of side effects. And so with my autistic kids, which I think perhaps are the ones you're referring to, I've started giving them very low doses of SSRIs, particularly nonverbal kids who are having trouble. And I'll tell you, I've really seen great results with that because, is it anxiety-based? It's very hard to know. But because I don't want to prescribe atypical antipsychotics, because the wait in Pittsburgh to see the autism psychiatrist is 1.5 years. We have to do something in the in-between. And so so that's become something that has been very effective, again, at very low doses. So I don't know what you think about that, Tanya, but what?
It can be disinhibiting in the very young kids.
Yeah.
A kid who's never been aggressive, hitting everybody, can suddenly be out of control.
So he's...
A 4, 5, 6-year-old giving an SSRI to a level 3 autism spectrum disorder, be careful.
Yeah, I haven't done it with younger kids. It's been like the 10-year-old, 11-year-old. Yeah, that's who I've, with the kids, but that's often when the kids are becoming so aggressive because they're older, they're bigger, teachers are more afraid of them. Those are the kids I've been doing with, so I'm sorry I didn't say that. But I do think it's worth a try in those older kids who are exhibiting those very impulsive behaviors, I would call them. So I don't know what the rest of you think. Go ahead.
I have a question about DMDD. Does anybody talk, is that off track here? To talk about mood disorders?
Yeah.
Okay.
Yeah, I was going to.
Yeah, go ahead. Why don't you talk about the medication? Finish that one first.
Yeah, is it okay? I'll just give a few thoughts about use of the atypical antipsychotics. So, I mean, in the case of and then we'll get to our DMDD question. So in the case of autism spectrum disorder, I mean, like Risperdal does have FDA approval. There's a lot of good studies to show that, you know, if kids are very disruptive and aggressive, that it, an autism spectrum disorder kid, that it can be helpful. So, you know, so we don't do it lightly, but we do definitely prescribe Risperdal in that case sometimes. For other kids, so more typically developing kids who have aggressive behavior, there is some good data that stimulant medications can be helpful with that, and, you know, titrating upward. So, I mean, I would exhaust, you know, stimulants first. I would try the alpha-2 adrenergic agonists first. Of course, as you indicated, would try the behavioral counseling before I would go there with the atypical antipsychotics. In the cases where sometimes I do end up going there. In cases where I would for a more typically developing kid, it's usually when they are considered to be a danger to others because of their aggressive behavior. And of course I provide all the counseling about the different side effects that we can see, the weight gain, the glucose intolerance, the liver enzyme bump, the lipid profile bump, the dystonic reactions that are possible. And I also let them know that we're going to have to monitor labs. We're going to be checking the glucose, the hemoglobin, A1C. We're going to be checking the LFTs and the lipid profile. So really make them, know that there are a lot of adverse effects, and we don't take it lightly.
Just to add to that, I typically would use it for kids with ASD and severe intellectual disabilities.
Yeah.
And they work beautiful. I mean, it's amazing. These kids
Yeah.
go from so many struggles to much struggle. So definitely follow all the guidelines.
Yeah.
But these families that are really struggling.
Yeah. And, if thinking, and I'm thinking of Judy Reinhold here, or, ASD, one of our experts, that in the case of the atypical antipsychotics with ASD, that, the guidelines will talk about, them having their use. And so it's a bit of, we all feel less qualms because of what the guidelines say in that case, ASD or intellectual disability, compared to a more typically developing kid.
Can you move on to the?
The DMDD question. Yeah, can you let us know your question?
I think it's just about treating, because a lot of kids we see a lot of kids with really intense anger that can go from like 0 to 100.
Yeah.
And the SSRIs don't seem to make any difference, or very little difference. But that's also, we see that with kids with ADHD. There aren't the medicines for that. There's the kids that are throwing the tables over at school.
Yeah, and I would call that aggressive. Yeah. And so that's when I would start thinking, if I've tried, the behavioral counseling, the stimulants I've tried, the alpha adrenergic agonists, and they're still throwing the tables, then I am having the discussion and probably pulling out the atypical. Yeah. Other questions?
Oh, one more question.
Yep.
I don't have a question. I just want to thank you all and ask you to say your names again, if you don't mind.
Sure.
She wants you to just say your names.
Yeah, Tanya Freilich.
Susan Van Cleve. Casey Krieger.
And their names are also in the in your paperwork that you have, but this way you can associate their faces with their names.
Yeah. And you guys have been an amazing audience, so we really want to thank you. We're very impressed with your sustained attention and your executive functioning and your general smarts. So
thank you, everyone, for coming. Thank you to the speakers as well. Everyone, please remember to return your clickers in the back. You can just put them into the little slots in the clicker bag in the back. If you go home with it, please contact someone and let them know you have it. They're really expensive. Thank you.